Assalamu alaikum. We'll start the long clinical consultation. We have Mrs. Sophia, 35 years, with complaint of red eye. Ready?
Okay.
Yeah, here we go.
Hello, my name is Dr. Abdullah. I am one of the medical doctors here in the clinic today. Can you confirm that you are Mrs. Sophia?
Yes, I am.
Yes, you are 35 years old.
Yes, I am.
Yes. Can you tell me what brought you to our clinic today?
I have severe, I noticed my eyes become red, doctor, recently, and I cannot tolerate anymore, doctor.
I'm really sorry to hear that. I will take some notes and be sure that it will be confidential, Mrs. Sophia. Can you tell me one eye or both eyes, please?
Yeah, the right eye.
Since when did this problem start?
Has been started since 3 hours now.
Never, this one never happened before, right? This is the first attack?
No, doctor, the first time.
All right. And you feel it's getting worse?
Yeah, doctor. All my eyes red.
I'm sorry. Any pain?
Severe pain, doctor. I cannot tolerate.
I'm really sorry. You want to be offered any pain medication?
Yes, please, doctor.
Yes. Here you are, Miss Sophia.
Okay, thank you.
Can you tell me the site of this pain is only in the eye? No other pain in your head or on your face?
Not in the face, doctor, but I feel headache.
Okay. And this is the first time this headache happens?
Yes, doctor.
Is this headache only around, you feel it only around the eye, or it's taking...
Yeah, most around the eye, but it's dull aching all over my head.
All right. Can I ask you before this pain, did you have any, I'm sorry to ask, any feeling of vomiting before this attack?
Yes, I throw up, doctor, yes.
Okay. Can you tell me the severity of the pain scale from 1 to 10? 10 is the severest?
Almost 8, doctor.
I'm really sorry to hear that. And you as you told me, you don't feel this pain is going anywhere in your face, in your head, in your body?
No, the headache, doctor. I feel the headache with this pain.
What do you feel that caused this pain? You have anything in your mind? You have noticed anything?
I don't know, doctor, what happened. I just was resting in my living room, watching the TV, and suddenly this pain comes.
No trauma, right?
No trauma, doctor, at all.
Okay. You feel anything that has make it better through this 3 hours?
Never, doctor. That's why I went to my GP. He referred me immediately to you.
All right. I'm sorry. Any discharge or any? I'm sorry to ask, any like pus coming out of the eye?
No.
Okay. Okay. You cannot see by this eye, this red eye?
Yeah, too much hazy and blurry.
Okay. Sorry, can I ask you if you had any weakness or any numbness in your body?
No, doctor.
Any problem with your walking?
No.
Or any shakiness of the hand?
No.
Any problem with your other senses like smell, hearing?
No, doctor. I'm fine.
You felt that your face is dropping or there is drooling of saliva?
No, doctor.
Okay. Any neck stiffness? You feel like
No.
neck stiffness, neck pain?
No.
Okay. And you did not feel this attack happened after hot bath or something, right?
No, doctor.
Okay. Can I ask you if you had any fever?
No, doctor.
Any weather preferences?
No.
Any weight changes?
No.
Any lumps or bumps in your body?
No.
Any joint pain?
No.
Any muscle weakness or muscle pain?
No.
Any hair problem?
Hearing or hair?
Hair problem?
No, I'm fine.
Okay. Did you have any skin rash or skin hyperpigmentation problem?
No, doctor.
Any stool change? Any bowel changes?
No.
Any urine changes?
No.
All right. Can I ask you if you had any past history? Past
No.
medical history? No problem in your health before, right?
No, no, I'm fine, doctor.
Any previous surgeries you had?
I had before appendectomy, doctor.
Okay. Since when is appendectomy?
Since 10 years.
Okay. And okay, did you have any problem in your family? When you have problems in your family?
Yeah, my mother was diagnosed with a disease called rheumatoid arthritis.
Okay. Sorry to ask you, did you have any sores like in your mouth or your private area?
No, doctor.
Did you have any? Sorry to confirm, you did not have any joint pain for your area, right?
No.
And you did not have any back pain, right?
No.
Any? No joint, like big joints in your body is affected or something, right? Or hand,
No.
or your joint of the hand, right?
Yes, no, nothing, doctor.
Okay. Can I ask if you are taking any medication?
No, doctor. I'm not taking any medication.
Any over-the-counter medication?
Sometimes, doctor, when I have headaches, I take paracetamol.
So this headache happened before, right? Because I want to confirm.
No, it's first time ever, doctor.
Okay. But you took the pain medication only during this attack. Never happened before, right?
No, not happened before, doctor.
Okay. I'm really sorry to hear that you are having problem with your eyes. Can I ask what's your job, Mrs. Sophia?
Yes, doctor. I'm a taxi driver.
I'm really sorry, Miss Sophia, to tell you that you better hold driving right now because of this eye problem and the vision problem with your eye, with your right eye. It's better to hold driving right now, and we have to inform the driving agency. Is that okay with you, Sophia?
Okay, doctor.
Are you smoking?
No?
Drinking alcohol?
Yes, I am.
How many units per week?
Around 10 to 12 units.
Okay. Do you feel that any kind of food or drinking alcohol led to this pain?
No, doctor.
Okay. Sorry to ask you some private questions, Ms. Sophia.
Mm-hmm.
Are you married or with partner?
I have partner, yes.
Are you on the pill?
Sorry?
Are you on the pill?
Yes, I took birth control pills. Yes, I am.
Okay. Did you have any did you have any pregnancies before?
Any clots?
Pregnancies before?
I have 2 kids, doctor.
All right. And last kid, how old is he?
He's 3 years now.
Okay. And no miscarriages before?
No.
Sorry to ask you again regarding this headache. This only has been for these 3 hours, right?
Yes.
Okay. And it's also taking the right side of your head, right? That's right.
Yeah, mostly behind the same eye.
Um. Okay. Can I examine
Yes.
you?
Yeah, doctor, you can.
Okay. Are you comfortable to examine you while you're
Yes,
with me?
I'm fine, doctor.
Okay. Can I check the visual acuity on the left eye first?
Yeah, in the left eye, normal, totally. She can read all the chart.
Yes, and the right eye.
In the right eye, no, she can't. She can see only the first line.
All right. What about the visual field of the visual field? I think it will be difficult to assess.
Excellent. Yes,
Okay.
you can't because she has
Yeah.
already
Mm,
the reduced acuity. So
mm, it will be difficult to assess on the right eye. طيب, visual movement.
she can't move any side because of the severe pain.
Okay. And
The H shape, you mean, right?
yes, the H shape. And the accommodation of course is lost also, right? Because of the pain.
She can't do any movement or
Okay.
follow by the right eye.
Okay. How about the local examination of the right eye?
Yes, severe redness in the whole eye.
The red reflex is seen or not? The red
Yes,
reflex?
yes, you can see, but the pupil in the right eye dilated and or semi-dilated. In the left eye, constricted normal.
Okay. How about the right? How about the light reflex?
The light,
Light
yes,
reflex.
it can't contract. Meiosis in the right, the left, in the right, hydrated. It's not responsive. No reaction.
Okay. How about the fundus examination?
Fundus, you can see papilledema. Yeah, that's it. Plus the pupil dilated, I said yes.
Okay. I feel I'm missing something, but okay.
No, you're doing well. Go ahead.
All right. Can I check the vital signs?
Yeah, blood pressure normal, heart rate normal, temperature normal.
All right. How about the neck stiffness? Any neck stiffness?
No neck stiffness.
Can I do screening of the neurological screening over the
Normal.
cranial nerves?
Yeah, all cranial nerves examination. If you want to start by one, all are normal. 2 minutes left.
Okay. Cannot make up my mind actually. Sorry.
No problem. Just collect your thought and you will answer it. Doctor, what I have, doctor, is it something serious? Why my vision blared now?
Actually, with taking history from you and also taking examination, I think I think that you have. I'm not sure.
Okay, doctor, is it related due to the TV vision when I was watching the TV and the room was dark? Is it related to that? Because I feel everything happened after this.
I don't. With examination after examination and taking history from you, I don't think it's related to watching TV.
Mhm. Okay, doctor. So what you will do for me now?
So we have to refer you urgently to the eye doctors
Excellent.
for proper management.
Okay. At least you refer, yes. If you
Okay.
don't reach to diagnosis, emergency referral
To
to the
the
ophthalmologist. Okay.
that's right.
So doctor, you will admit me.
Yes. We will need
Okay.
to admit you urgently, and we will
Excellent.
need you to refer you to
Okay.
the eye doctor.
Okay. Time is up. Just try to collect your thoughts, what happened, and correlate the symptoms. Then we'll start the examiner question. When you're ready, tell me. Okay, you
I'm
want to
just
start? Let's start. Okay.
I'm just discussing with myself actually. I'm thinking in the first
Okay.
I was
Okay. Dr. Sarah, give me differential. Don't give me
okay.
diagnosis. Give me differential diagnosis and one by one. Did you roll it out?
Okay. So yeah, I'm thinking of something local in the eye more than it is systemic.
Excellent.
But because of the papilledema, it made me think about something also central. I'm not sure if we're going. Yes. I think.
Go ahead. Go ahead. Yes. What's differential for red painful eye? Simply.
Okay. Either it can be in, yeah, and it can be from the outer layer, like infection or uveitis. But I think it's something because of the papilledema. It has to be increased pressure or something. I'm not sure.
Excellent. Yes. Yes.
Glaucoma?
Perfect.
Really? And it will come in basis glaucoma? Because
Yeah. Go ahead. Continue. Don't ask coming or no. Continue. So you think about glaucoma. Which type of glaucoma?
I'm not sure. I think because of the uveitis.
Okay, so first differential is glaucoma, and second differential with pain. Scleritis.
Scleritis. This is what I meant. Scleritis, uveitis.
Yes, scleritis. No, to be painful. Scleritis, redness with painful. Okay.
But scleritis will not affect the pupil movement, right? It has to be something
yes. Yeah, so you will say against that. Okay. What other red eye with pain causes?
Other
infection, conjunctivitis, for example. Or conjunctival hemorrhage due to any rupture vessel or whatever.
But it will not lead to the papilledema and
exactly. So this is so for each differential against, you have to think. Okay, what you will do investigation for this patient?
So first of all, apart from basic investigation, CBC, kidney function test, liver function test, and electrolytes, we have to refer urgently to the ophthalmology for pressure. I'm not sure what's the name. Yeah, they will take the pressure of the eye urgently.
Tonometry.
Tonometry to get the pressure of the eye if it's to confirm glaucoma or not.
Okay.
But because of the papilledema, I'm not sure if we have also to exclude central cause or not. Like we have to do CT or MRI. We can think about it, but
no. Only tonometry can diagnose. Okay. And there is what's called gonioscopy. It will look to the angle, and it will show is it closed or open from the side. Yeah. And also this is diagnostic. Okay. You diagnosed acute closed angle glaucoma. How you manage this patient?
Right now I can't remember.
Yeah, okay. Leave the pharmacological. Don't think about just pharmacological therapy.
So first of all, non-pharmacological, like patient education, patient counseling, and like that. Yes, the watching TV will be related if it's really glaucoma.
Excellent. Yes, exactly. This is
So
the
what?
reason. Okay.
Okay.
Okay. So what education and advice you can give here,
To avoid stress for the eyes, she has to avoid a long period of time watching TV or watching the mobile,
especially in
and especially in dim light, she has to be
ex
always
in dark,
in
yes, in dark, yes, in dark light, or dark room.
a dark
Okay.
room.
And driving, you can give some advice about driving, is it?
I
Yes.
think right now she has to avoid driving.
Excellent. So
Yes, because of
if you don't find something to say, you can mention these things. You don't know,
صح. Yes, that's right. Yes.
right? So you'll talk about some advices, and that's it. Then multidisciplinary team. What team you will involve here?
Uh, should be the optometrist and the ophthalmologist.
Okay. Specialized
The
nurse,
specialized
education.
nurses
Yeah.
and the
Okay.
educator.
What pharmacological you know?
There
Either
is this.
okay, either two or okay. I will say this.
Mm.
Either medical or surgical. Okay. Medical,
Okay.
something to reduce the secretion and something to increase the excretion.
I think.
Parasympathetic mimetic
Okay.
is to, I mean, the pupil will be constricted and you can drain. This is
Okay.
called pilocarpine, vasoconstrictor, pilocarpine. And for the decrease excretion or secretion, sorry, decrease secretion by acetazolamide injection, IV acetazolamide. And the surgical treatment here will be iridectomy, laser iridectomy. Okay, because it's the pupil dilated makes the angle closed because of the dilatation of the pupil. So you have to open this by laser or opening the iridectomy. I mean. Okay.
Okay. Okay. I
Yeah, I
never
know
had
it's
glaucoma of
yeah,
that.
of course it's a rare case, but
Okay.
at least you have to roll some differential, very important in this age. One of them, multiple sclerosis, you did it, optic neuritis as a cause of eye or painful eye. GCA also, and you screen for GCA, giant cell arthritis. You ask about muscle pain, joint pain. I know you are roaming around, but it comes in age, later age. I mean, 50s or more
Yes.
than 50s. But at
Actually,
least you put it. Yes.
I was roaming around. I was roaming around some rheumatological disease like
Okay.
seronegative
Oh,
or GCA or something like that. Yes.
yeah, the take-home message from this case scenario: don't stuck if you don't know how to manage. You can say anything and just give some advices, give differential, even you don't know the top diagnosis. All of us might face a rare or a very rare case in this exam, but will not be stuck and just be quiet. If you think more, I told you, is it related to watching TV in dark room? Yes, it is. So this is the precipitating factor. If you ask me also, I had a glass and I can't see far away good. Yeah, hypermetropia, I think this name.
Yes.
So yeah, these are the risk factors. Apart from this, the eye will be severely painful, plus red. All the sclera will be red due to increased intraocular pressure. You will do that by measuring the intraocular pressure, tonometry, and you will also do gonioscopy. It check the angle of the drainage, which is called aqueous angle, I think, for drainage of uh, the eye fluid. Also, you can put cluster headache, but against cluster headache, it comes more in the males. But
Yes.
still, red eye with tearing, and also you have to ask this question. You have any tearing, but you ask about discharge to rule out infection. Yes, you're right. So you got the case at the end. Don't be stuck again. The headache will be associated in these cases, along with vomiting. It will be also associated with vomiting. Apart from this, you'll not find any symptoms, only the precipitating factor and the associated symptoms, which are headache and vomiting. However, you have to rule out the common cause of painful eye, including the GCA, including also the our case here, acute closed angle glaucoma. And as we mentioned earlier, you can say cavernous sinus also will be, I think also maybe it will be painful because of the congestion. But also you can rule out by any infection before. Okay.
Okay.
The subconjunctival, I mentioned the subconjunctival hemorrhages, but if traumatic one, it will be painful eye. Okay, but subconjunctival hemorrhage due to bleeding tendency or whatever the reason, yes, it might be painless. But due to trauma, it will be painful. The other painful eye will have optic neuritis in multiple sclerosis, but also it will not be red eye. Red eye with painful eye, including scleritis and rheumatoid arthritis. Okay. I think this is the differential.
Dr.
GCA.
Barton,
Yeah.
can you repeat the differential again? Sorry.
Yes. So you can put at the top, because of the precipitating factor, the vision in dark room, you will put acute closed angle glaucoma. GCA also one of the painful and red eye. This is another differential. Scleritis, one of the red and painful eye. Scleritis. It might be also associated with rheumatoid arthritis. This is the commonest in bases, I mean. Okay. Where let's read the comment. Dr. Sarah, please read write the scenario. I want to start after reading the comment quickly. Cavernous sinus thrombosis, venous sinus thrombosis, yes, might be also there. Especially OCB, yes, I agree. Cluster headache, also good differential, but suppose patient will have tearing and the headache will come in clusters, but also it can be rolled out by history. Yeah, the medication acetazolamide. Yes, you can talk. Anyone want to add the comment? He can comment.
السلام عليكم دكتور باسم.
السلام ورحمة الله وبركاته. Yes.
Does the acute angle glaucoma can be the first presentation like this?
It will be, yes, acute onset and acute, hyperacute.
There is no need to be there as a previous episode, like not like a close angle glaucoma presentation, like mild pain, like something like some blurred vision, some drug history or something. And we can put also the drug-induced glaucoma in the differential, by the way.
You mean the open angle?
Even the closed angle.
This is what I know as a presentation. It will be hyperacute, and the precipitating factor I mentioned, the vision night in the dark room, I mean. And yeah, patient had far the difficult to look far away. It's hypermetropia, yes. This is what I know. If you have, you can add. If you have any other information, you can add it to us.
Just like that is closed angle glaucoma will never be the first presentation of the glaucoma. Just like this, there should be some history, like some pain, some blurred vision, something like this. And I think we need to dig into history also for the causative agents, like steroid, like sulfa use, like something
No,
like this.
I didn't found in the topic of acute closed angle glaucoma any drug can cause it. But it's okay. You can share with us in the WhatsApp group, or you can share it here. We can read it.
Okay.
Yeah, it's associated with nausea, vomiting, and headache because of increased intraocular pressure.
Ocular pressure.
Yes, exactly. And the tonometry gonioscopy is the tool to use to diagnose the case. And your pupil will be dilated. The other pupil will be constricted or normal reactive to light. Okay, Dr. Nora adds also cavernous sinus as a cause. Yes, I agree. You can put it in the fourth or the second after. You will have also congested eye. So the differential, you can put according to the history, not only what I mentioned. If you see or you feel or you have sense that this differential could be better or before what I mentioned, you can put. So if you want to remove, you can remove GCA because it's not coming at this age. However, all of them you will say against that because the only thing can matching the differential here is acute closed angle glaucoma. The scleritis, you can say against scleritis, there is no rheumatoid features. Against GCA, no polymyalgia rheumatica or association of GCA, giant cell arteritis. And also there is you will have facial scalp pain. This is with GCA. Also claudication in the jaw claudication. So every differential you can say what's against. Cavernous sinus thrombosis you can put, but you will say against that no history of infection, also no signs of increased intratracheal pressure. However, there is papilledema, yes. So all of them can be put as a differential. So we can add also cavernous sinus thrombosis, venous thrombosis, I agree. Yes, age-wise also GCA, exactly. The age will be 50s or 50 and above as a case of PMR, polymyalgia rheumatica. As Dr. Sarah said, it's not common in exam, but you might have other case like MS, and you have to screen for the red pain or painful eye, red eye or painful eye. So in MS, multiple sclerosis, you will have the positive of the phenomena, increase or worse symptoms with hot shower and optic neuritis. You will have also change in the vision to the color or a change in the color vision, plus the weakness or other signs, symptoms of multiple sclerosis. So I just put the case to learn from. Maybe it's not common that much, but you can you learn how to approach for red and painful eye. We know how now about the red, and we know also about the painful eye. There is another category which is painless eye. We can do another case another day. Painless eye will be another differential. I mean, especially the thrombosis, central retinal vein thrombosis and central retinal artery thrombosis. We can do it another day. Okay, Dr. Sarah, did you write the scenario?
Yes, I wrote it down. I think I will write it again because it will be in between the comments.
You might send to someone as a reply.
No, I wrote it, but I will write it again.
Yes, I found Mrs. Lisa, 29, fatigue, 3 months. Okay. Okay, let's start because we have 2 more cases today. You can see the timer?
Okay, yes.
Okay, hello. This is Dr. Mukhtar, the doctor in the clinic. You must be Miss Lisa.
Yes, I am the doctor.
You are 29 years.
Yes, doctor.
I read in your note that you have some fatigue. Can you tell me more about this?
Yes, doctor, I cannot, for these past 3 months, I cannot do even my daily activities, even the simple chore that I have at home. I cannot do any social gathering I will miss, just because I really feel so fatigued, doctor.
I'm so sorry for your suffering, Mrs. Lisa. And do you notice the fatigue being more weak and worse?
What do you mean, doctor? You mean over the 3 months? Yeah.
Yeah, it's worsening.
Yes, I think it's worsening, doctor. Yes.
And it started all of a sudden or gradually?
I think gradual, doctor. I feel it has been.
Gradually.
Yes.
Okay, anyone with you can help you or how you can cope with your activity at home?
I actually asked my sister to help me at home, doctor, because really I cannot feel
Yeah.
myself doing any basic, even things I need to do at home.
Okay, if you need any help, we can do this for you.
Thank you so much, doctor.
Okay, back to your fatigue. What do you mean by fatigue?
It's like not having the energy, doctor, to do anything. It feels like I'm really low in my energy, doctor.
Mm-hmm. Okay. Apart from this, do you feel dizzy?
Sometimes, doctor, yes, I can feel dizzy sometimes.
Okay, is this dizziness while standing from sitting?
Yes, when I stand from sitting position, doctor, I have some dizziness. Sure.
Okay, anyone told you you are paler than before?
No, I don't think, doctor. No,
Anyone told you your eyes looks yellow?
no, doctor.
Okay. How is your appetite, Miss Lisa?
I feel it is the same, doctor. No change.
And how is your weight?
Actually, I feel that because I have been really fatigued this previous 3 months, I have gained a lot of weight, doctor.
How many over how long?
Actually, I gained almost 9 kilograms, 10 kilograms over the previous 3 months.
Okay. Do you notice the distribution of the weight in particular area?
I don't think, doctor. I got only heavier all over my body.
All over, okay. And any lumps or bumps in your body?
No,
Any high body temperature?
no,
Any night sweats?
no.
Okay. Are you intolerant to certain weather? For example, you don't tolerate the cold weather?
Yeah. I feel that when I'm in cold weather, really, I feel so cold, really. So I prefer the warm weather, yes, actually.
Yeah. Okay. Along with this, do you notice loss of hair? Any area in your body, especially the outer third of your eyebrows, sorry?
No, I did not notice this one, doctor.
Okay, you have any hard stool
Yeah,
or
doctor.
hard,
Yeah.
you notice?
Yes, I have heart stool, doctor.
It's the same period?
Actually, I missed my period, doctor, actually. I have missed my period for the previous 2 or 3 months.
Okay. Any apart from your period, you notice the amount being less then disappear, right?
I think, yes, I'm not sure what happened, but I think, no, previous 2 or 3 months, I supposed to have my period, but it did not.
Before that, you were okay?
Yes, doctor, I was okay.
Okay, and any delivery recently?
Yes, doctor, I delivered around 5 months ago, doctor.
And the delivery was okay and eventful?
Yeah, but actually, I had this bleeding that time. But they gave me some blood, and then after the blood, I become better, doctor.
Okay, you could lactate your baby?
No, actually, I asked the doctor about that, and he said maybe because of blood loss, I cannot give any milk to my baby that time.
Okay. I'm so sorry for all this suffer, Miss Lisa. Apart from this, you have any headache?
Uh, no headache, doctor.
Any vision problem?
No,
Any hearing problem?
no,
Unsteadiness?
uh, no, doctor. Only the dizziness when I stand up. Only.
Okay. Any fainting attacks?
No,
Okay. You have any difficult swallowing?
no,
Any chest pain?
no,
Any awareness of your heartbeat?
no,
Okay. Any short of breath?
no, doctor.
Any change of your apart from your bowel habit, hard stool? You have any problem in the tummy? Any tummy pain?
No, doctor.
Okay. You are sleeping well, Miss Lisa.
Actually, yeah, I have no problem with sleeping, doctor. Actually, I sleep more than supposed to be.
And how's your mood?
Yeah, I feel with low mood, doctor. Actually,
Okay. Sorry for that. You have any change in your water work?
no, I did not notice anything.
Any joint pain?
No,
Any muscle pain?
no,
You have any difficulty while combing your hair or
yes,
climbing the stair?
yes, doctor. I feel it's really difficult to do so.
Okay. Any family history of same problem?
No, doctor.
Any family history of gland problem?
No,
Any long-lasting disease I should be aware of?
no, doctor.
Any surgery before?
No,
Any allergy to any medication?
no.
Okay. And you told me about blood transfusion, right? You received once?
Actually, during this last delivery, because really I lost a lot of blood, so they had to give me some bags of blood. They told me they gave me about 2 or 3 bags of blood.
Okay. Are you taking any medication right now?
No,
Okay. What's your job, Miss Lisa?
actually, I was a secretary, but now I did not go back to my job as I'm still with a baby, doctor.
Okay. If you need any support, let us know.
Okay, thank you so much, doctor.
Do you smoke?
No, doctor.
Do you drink alcohol?
No, I stopped drinking alcohol since I got pregnant, doctor.
Okay. Now, may I examine you?
Yes, please, doctor.
Okay. Starting by the general look, patient BMI.
Around 36.
Okay. And the vital chart, blood pressure, heart rate.
Blood pressure 130/70. Blood pressure standing is 90/60. Heart rate is about 60 beats per minute.
Pulse volume is okay?
Pulse volume is a little bit low.
Okay. I'll examine now for the palm. Any cold?
Yeah, it felt cold. Her palms.
Okay. Any skin change, any darkening of the creases?
No darkness, but it's like thick skin.
Thick skin. And at the back, also thick skin.
The back also, yeah. There
I
is
will offer blood sugar measurement.
normal.
Normal. Okay. Any pain in your palm? If I tap here, I mean carpal tunnel. Any signs of carpal tunnel?
No, doctor.
Okay. The power of the hand is okay.
Yes.
Okay. Let's check now for proximal myopathy. Can you do your arm like this and resist against me, up and down?
No, it's difficult, doctor. I can't.
Difficult. Okay. Okay, Miss Lisa, and now I'll examine the face, the eyebrows, any loss of hair.
No.
Nothing. Okay. I will examine and offer for visual acuity, visual field,
Visual acuity and visual field are normal.
acuity and field normal. Pupil reflex,
Okay, it's okay. Nothing. The people
nothing. I will offer fundoscopy.
Fundoscopy is normal also.
Okay. Any pallor?
Yeah, she seemed pale, yes.
Okay. The distribution of the fat in the face, any buffiness?
I'm not sure if we can say it, but yeah, it's round face.
Yeah, large tongue, large mouth.
Yes.
There is the neck circumference,
Uh, yeah, it's about
increased.
Yes, increased. I cannot remember the number. Sorry.
Okay. The eyebrows, you told me no loss of hair, right?
No.
Okay. Now I'll examine for the thyroid itself. Starting by the inspection, can you take a sip of water, please?
Yes.
Swallow. Is
Yes.
it moving? Any goiter?
No. No goiter.
No goiter. Okay. I will examine for the thyroid and also if needed for auscultation, percussion, retrosternal. Any signs?
No.
Any
No.
goiter? I mean retrosternal. Nothing.
No.
Okay. The skin in the back, any acanthosis nigricans?
In the you can find in the axilla. Yes.
Okay. I will examine now for SGVP. Press over your tummy. Any tummy pain?
No.
Any heart failure signs?
No.
I will detect the apex for any displacement.
Normal.
Normal. Okay. Any murmur?
No.
Quick examination? Nothing.
Yes.
I will offer for lymph node in the neck and axilla.
Negative.
Negative. Abdominal examination. Quick examination, by general inspection, any scar. Yeah, I will find cesarean scar, right?
Yes, there is cesarean scaries.
Okay. The tummy fistria, abdominal distension, right? Abdominal distension all over.
Yes, all over. Yes.
Okay. The knees for osteoarthritis. Any signs of osteoarthritis?
Negative.
Negative. And the ankle, any edema?
No, edema. No.
Okay. Any joint problem at all, Miss Lisa?
No. No, doctor. 2 minutes from.
Okay. What's your concern, Miss Lisa?
Doctor, why I have this fatigue, doctor?
Yes.
My baby, I have a small baby I have to serve. How can you help me, doctor?
I appreciate your concern, Miss Lisa. Yeah, we can help you in this regard by involving our a group of specialists and doctors. They will help you for diagnosis and management. You have any other concern?
Yes, doctor. Is this disease curable, you think?
It's not curable one. However, we can control this. You have condition called panhypopituitarism. It's happened due to the bleeding after the delivery, and we call it Sheehan syndrome. Don't bother about the name. Your glands in the maestro gland inside your brain being harmed because of the bleeding, and for that all hormones coming from this maestro gland controlling the growth, including the lactation, also for the thyroid, and the last thing, the period. All these glands will be reduced and low due to the harm happened during pregnancy and delivery. For that, we have to give you a replacement for all these hormones. Hormones mean some proteins in the body need to be corrected and need to be in the normal range. You have any other concern?
Will I be able to have more babies in the future, doctor?
Yes, you can after giving you the whole replacement you need.
Okay, thank you, doctor.
Okay, time's up.
Okay, what's your diagnosis, doctor?
Yes, this lady, Miss Lisa, 29 years, came with fatigue for last 3 months. By taking history and after examination, I could say I believe this patient has Sheehan syndrome, evidenced by postpartum hemorrhage and bleeding, for which she received blood transfusion. And these symptoms started after the delivery. She delivered 5 months back, and the symptoms started 2 months after delivery. She has signs and symptoms suggestive of hypothyroidism, hypoprolactinemia in the form of failure to lactate, also Addison in the form of posture hypotension and dizziness. She had also low gonadotrophic hormone, as she has amenorrhea since 3 months. So putting all together, these symptoms and signs suggestive of Sheehan syndrome.
Okay, what's your differential diagnosis?
Yes, my differential will be panhypopituitarism for other reason like infiltration or radiation or lymphocyte infiltration or surgery. However, no surgery here. Other differential, postpartum cardiomyopathy, peripartum hypothyroidism, postpartum hypothyroidism, one of the differential. It might happen after delivery as well.
Okay, how can you investigate the patient?
Yes, apart from general investigation, CBC to look for anemia, and all other general investigation, I will do here a specific investigation, including the hormonal assay in the form of ACTH, cortisol level, growth hormone level, FSH and LH level, which all will supposed to be low. Prolactin level as well will be also low. Apart from the blood workup, I could think to do image in the form of MRI pituitary. Suppose it will show empty sella torsica, and other investigation for the complication. I think, the thyroid itself, the thyroid screening, TSH and T3, T4.
Okay, how can you treat this patient?
Yes, starting by multidisciplinary team approach, including endocrinologist and the psychologist, and also a specialized nerve physiotherapist and GP, social worker, and occupational worker, because she doesn't find any support, I mean, for her daily activity. Apart from that, education, counseling about the disease and complication. This is non-pharmacological therapy. The pharmacological therapy will be hormonal replacement, starting by the steroid and thyroid hormone, levothyroxine, and growth hormone. And for the induction of ovulation, she might need also some combined contraceptive pills.
Okay, thank you, doctor. Okay.
What? Still 50 seconds. Finish the question? Okay.
I don't think, no, I don't have other questions actually. Sorry.
Okay, thank you. Thank you, Dr. Sarah, for the case. You can comment now.
So, yes, this case of Sheehan syndrome, fatigue and weight gain after delivery. Actually, in such case, once you have patients with fatigue and weight gain, you have to ask about all the endocrinological diseases that can lead to that, like hypothyroidism, Cushing syndrome, polycystic ovary disease, acromegaly, and you have to do screening for all of this. For this patient, because she had signs of hypothyroidism and Addison disease, and also she had amenorrhea. So you have to think about something polyglandular. The key here is that she had a failure of lactation after delivery. So if you have failure of lactation after delivery, you have to suspect Sheehan syndrome. To confirm Sheehan syndrome, you have to ask about the circumstances of the delivery itself. What was the type of the delivery? Is it vaginal or cesarean? And you have to ask about if any blood loss. Some people will say that blood loss will differentiate between Sheehan and another type of pituitary dysfunction also that will happen after delivery. They call it lymphocytic hypophysitis, but I think both of them have the same management, and both of them will not lead to any affection of the vision or papilledema. So both of them will become after delivery. The difference only in the blood loss. One of them, the Sheehan, will have blood loss. The other one, the inflammation of the pituitary gland, will not have any blood loss. Then the third differential will be a pituitary aplexy, but pituitary aplexy will have the headache, the loss of consciousness, and the visual disturbance. Then yes, you can other causes like the postpartum hypothyroiditis, even polycystic ovary syndrome or Cushing. This one we cannot say it here, but yes, postpartum thyroiditis is one of the differential diagnoses. Then the management, as you said, doctor, we have first of all the treatment. First of all, the investigation. You have to do the basic investigation: CBC, kidney function test, liver function tests, electrolytes, of course, because of the Addison, and you will do specific investigation. You have to do screening for all the hormones, like TSH, ACTH, FSH, LH, growth hormone, IGF-1. Growth hormone will be here. You will do clonidine stress test because of we can. This is the only one we can do. Also, we have to do the other hormones like the T3, T4, and you have to do the estrogen and progesterone also, and of course the cortisol level. You have to cover all the hormones, either central or peripheral. Also, you have to do MRI brain to exclude apoplexy. Very important to do MRI brain to exclude apoplexy. And then the management, as you said, the non-pharmacological, the multidisciplinary team, the education, counseling, psychological support, and the occupational support. The pharmacological replacement of the steroids before replacement of the thyroxine. And of course, if she wants to get pregnant, you have to give her cyclic FSH and LH to get her to ovulate, so that she can ovulate, and because she's thinking of having babies also, you have to give her FSH and LH for the ovulation. That's it. I'm not sure if you have anything else.
Yes, perfect. So we have to give FSH and LH, not combined contraceptive.
Combined, if she's
Combined,
having
if she wants to have period without pregnancy, but if pregnancy,
yes,
it should be induction by FSH and LH. You're right. Yes.
yes, that's right.
Okay. Thank you, Dr. Sarah.
Thank you so much.
Nice case. Gain cause of hypo. Okay, let's read the comment. Any comment? Anyone want to comment? Yes, nice case. Postpartum thyroiditis. I said it's postpartum hypothyroidism. No, it's postpartum thyroiditis. Yes. I think weight gain should be loss, not gain. No, she will because of Addison. You mean, right? Right, Dr. Onaida? Or who asked? Dr. Ahmed? Yes, he's saying loss of weight. If Addison, yes, she might loss of weight.
Yeah, but if hypothyroidism should gain
Yes,
weight, right?
exactly. The hypothyroidism, yes, she will gain weight. Yes.
Also, Dr. Basim, we should screen symptoms of all pituitary profile and symptom-wise, right? Like hypocortisol and hypogonadism.
Yes, yes,
and
I screened all.
yeah, all pituitary profile. Yes.
Okay,
well
Yes.
done.
there is one thing that you should screen also for the polyuria, for the
Yeah,
diabetes.
DI might happen. Yes.
Yes, so you have to screen for it because also it will differ in the management. You may add the percent.
Yes. Okay. Okay. Thank you, Dr. Oneida, Dr. Sarah. Any comments? Well done. Thank you, Dr. Oneida. Okay, let's go to the next turn, Dr. Shaima and Dr. Aisha. If no more question for this scenario. Okay, we have long session today. So let's start, Dr. Shaima, Dr. Aisha. Are you ready?
Yes, I'll give the case first. Okay.
You will give?
Yes, the case first.
Okay, Dr. Shaima, you're there? You're ready? Oh my God, Dr. Shaima, I think not there. Okay, write the scenario, Dr. Aisha. I will message here, okay?
Okay.
Dr. Aisha, can you call here, please?
Okay. Just I'll close and come again to call. Okay.
Okay, we'll wait for you.
دكتور باسم معلش، طيب المقاسات بتاعت النك ايه عشان ما تتبعتش؟ ايوه بسبيك العربي بس.
Yes, circumference of the neck in male and female.
I forgot about the numbers, sorry.
I am not sure about the number as well. Because
Okay.
always I'm mixing between the waist circumference and the neck circumference. But I remember 93, I think, and I'm not sure also if someone can update it.
Think for male 17, more than 17, and female 16.
This is the neck circumference, right?
Mhm.
Neck circumference. Okay. What about the waist?
Waist was 100, I guess, 190, 90 plus. Anyway, Dr. Sarah, if you're not remembering, you can say increase the circumference of the neck, increase the circumference of the waist.
Do you have-
And no, you don't have to.
Okay. I mean, you have to measure, right? At least
Yes, you will offer. Tell him or tell the examiner that it might be increased.
Okay. But
But yeah, as exact number, I think he will not ask. If you know, you can say. If you don't remember, just say increase. But don't give wrong number.
okay.
Okay, ready? وعليكم السلام ورحمة الله وبركاته. Ready?
وحضرتك قلت لي بكره، انا تخيلت انه خلاص بكره.
دكتور شيماء، دكتور عايشة said she will take the case with you.
اوكي مفيش مشكله، انا جايبه كده
Okay.
معايا كيس. اوكي
She gave you the first. Also, she gave you the case first.
اوكي مفيش مشكله.
Always follow the group, Dr. Shayma. I wrote in the group that you will be with her, Dr. Aisha and you.
والله ما شفتش ده، انا
It's
تخيلت
okay.
ان هو خلاص كده وانا اشتغلت يعني.
It's okay. You can start. Prepare yourself for the case. Mr. Ali, 25,
تراني
with complaint of chest pain for 5 days.
ماشي اوكي.
Okay.
بسم الله ماشي اوكي.
We'll give you 2 minutes, then we'll start. Thank you, Dr. Aisha, for calling here.
اوكي دكتورة غير ان شاء الله. يلا عايشة.
تمام يلا.
Okay. You can see the timer.
Yes.
تمام.
Okay. Here we go.
Good morning. Good morning.
Good
I am
morning.
Dr. Radha, the doctor in the medical review day. Nice to meet you. Are you Mr. Ali, 30 years old,
25.
25 years old?
Yes, doctor.
Okay, Mr. Ali, today we are here to discuss the issue related to your health, and I will examine you. Is it okay with you?
Okay, doctor.
During our discussion, I will write some notes. Be sure it will be confidential and my full attention will be with you. Okay?
Okay,
Mr. Ali, Mr. Ali, it came to my knowledge that you are complaining of chest pain. Can you please tell me more about that?
Well, doctor, I have a bad chest pain that I found it a difficulty to take a good breath for the last 5 days, and also I found me not well. I staying at home. I can't go out. I really feeling sick.
I'm sorry for that, Mr. Ali. Mr. Ali, can you please tell me when this is chest pain started exactly?
5 days ago.
5 days ago. It started suddenly or gradually?
Yes, I woke up with this chest pain.
Okay. Is this first time to have this chest pain, or there is previous attack?
Really, doctor, I remember that about 3 years ago, I have really bad also chest pain. But at this time, I didn't seek any consultation. Just I take some painkiller and it settled.
Since 3 years back.
Yeah.
Same chest pain?
Yes, I think
Why?
I remember because it is really bad pain.
Okay. Please, Mr. Ali, can you please tell me, is it increasing, decreasing, or the same?
For these 5 days, I hope it will be okay. I take some painkiller and it can help. But when I found that I am 5 days now, no help, so I come to review.
Okay. It is not decreased by painkiller. Did you notice
Yes, it
anything
is.
that decrease it?
Yes, the painkiller is good, but if I didn't take it, come back.
Mm. Okay. Did you notice anything that increase it, like exertion?
While breathing, doctor, if I make any effort that require me to take deep breath, I found it is very painful.
Okay, I'm sorry for that. Mr. Ali, what is the nature of this pain? Is it sharp stabbing? It is cold? It is heatiness?
I don't know really, doctor, just it is like very bad pain, very sharp pain, including all my
It is radiated
chest.
anyway for all my chest, including all
Yes,
my chest, not
yes.
specific side of
It
your
is
chest. It is radiated to
it
any
is
side.
more arthritis, but I found it all over.
What?
More arthritis.
I'm sorry, more
More
arthritis.
arthritis. Yeah.
Okay, okay. Mr. Ali, if you use for this pain, 0 is the least and 10 is the maximum. How much use for this pain?
If I didn't take the painkiller, doctor, it is like 9.
I'm sorry for that. Do you want any painkiller now?
No, I'm fine. I took it early.
Okay, Mr. Ali, do you have any is this the chest pain decreasing by leaning forward
I
or
didn't notice
increasing by
clearly.
down?
I didn't
Okay.
notice this, doctor.
Did you have any high body temperature?
Yes. I noticed that like 2 days before when
Yes.
my sister trying to help me and ask to measure my temperature, and it's found like better, like little high than normal.
Okay. How much exactly did you remember?
She said that it's 38.2.
Okay. Okay, Mr. Did you have any sweating
No, doctor, no.
any sweating at night?
No,
Any loss of weight?
no,
Any loss of appetite?
no, doctor.
Any tiredness? Any feeling
Yes,
sick?
at this time, yes, at these 5 days.
You have tiredness. This tiredness
Yes,
present all over the day, not
yes.
specific to specific time of the day.
No, all the day, doctor. I didn't go anywhere in these 5 days.
Okay, I'm sorry for that. Do you have any feeling sick? Any throwing up?
No, doctor, no. Didn't
Do you
throw.
have any?
Mm.
Okay. Do you have any cough?
No cough, doctor, no.
Any cough of blood?
No,
Any noisy chest?
No, I didn't notice that.
Okay. Do you have any heart racing?
No,
Okay. Do you have any shortness of breath?
really, doctor, I found because I can't take a really good breath. When I walk, yes, I feel that I can't really walk just for short distance. I feel very tired.
Okay. Do you have any recent illness, flu-like illness, or sore throat, or throat pain,
No, no,
or ear
doctor,
pain?
no, no any,
Don't-
no any,
No. Okay. Do you have any headache?
no,
Okay. Do you have any jerky movement, any weakness?
no, doctor.
Okay, Mr. Ali. Do you have any post-medical illness or surgical operation should be aware of, Mr. Ali?
Yes, doctor. When I am 18, I run operation to remove my appendix.
Appendix.
Yeah.
Any other medical, any post-medical illness rather
No,
than appendix?
no, doctor.
Any tummy pain?
Yes, I have tummy pain on and off, and also I go to hospital many times for that.
Have you ever investigated for this tummy pain?
Really, I run some tests, doctor, but it is okay and become better, so they let me out.
Okay. Do you have any tummy distension, any loose motion,
No, doctor, no, really,
any
no,
hard motion?
no, really, no, doctor.
What about your water work, Mr. Ali? Is there any change in water work?
No, I didn't notice any problem in.
Frequency, amount, color, any
No,
urine?
no, doctor,
Okay.
no,
Do you have
not
any
really.
joint pain, Mr. Ali?
Sometime, doctor, yes. It's
You
on
have
and
joint
off
pain
also. Yes,
on and off. Which
yeah.
joint exactly?
It is mostly at my knee and elbow, doctor.
Knee
And
and
yes, and sometimes
mm,
some swelling happen.
some swelling in joint happen.
Yes,
Okay.
sometimes. It is
Okay.
about 1 year the last time I found this
Mm.
problem,
Have you
but
ever
it is settled
investigated this?
also. No, it is settled also in some medicine. I
Painkiller.
expected this is some trauma because I playing football a lot, so I
Mm.
usually suspect that this is the cause.
Okay, Mr. Ali. Mr. Ali, do you have any skin rash?
No, doctor, I didn't notice any.
Okay, Mr. Ali. Mr. Ali, do you have any family history of note of similar condition?
Yes, doctor, I have not similar, I think, but I have my father has kidney problem at young age, and he like on replacement therapy, like kidney replacement therapy, but we lost him in these days.
I'm sorry for that. I'm sorry for your loss. Please accept our condolences.
Mm,
Sorry for your loss,
thank you.
Mr. Ali. Mr. Ali, did you have exactly what your father had? Is it a familial? Anyone other than your father have have any problem?
Really, I don't know, doctor, about others, but no, I don't know about other family member if they
Your
have
father
sick.
died because of bleeding inside the brain?
No, no one. I
No.
don't know. I don't know. Yes.
Okay. Okay. Any other family history of note?
No, doctor, but they told me that like my father have same issues like me when he is young.
Okay. Okay, Mr. Ali. Okay. Sorry for that. I'm sorry. Okay,
Mm.
Mr. Ali. Mr. Ali, what do you do for living, Mr. Ali?
I'm student, doctor.
Okay. With whom you are living?
With my mother and sister.
Are they supported?
Yes, really. Mm.
Do you want any type of support?
No, thank you, doctor. Thank you.
Okay.
Just my college. I found it is hard. I didn't go last 5 days.
I know. I'm sorry for that. I will try to help you and I will involve the social worker, and I will write a medical report for you as excuse about the attendance for these 5 days.
Thank you, Willy. This can help really. Thank you.
Okay. Do you smoke?
Yes, sometimes, doctor, but it's like 1 or 2 cigarettes per day.
I advise you to stop smoking, Mr. Ali. You know it has a very bad side effect in your health. Do you drink alcohol, Mr. Ali?
No.
Okay, Mr. Ali. Can I examine you, Mr. Ali, please?
Okay. Okay.
I will examine your hand first. My pulse.
Yes,
Vital data
pulse.
كلها. Vital.
Yes, vital signs always normal now. Blood pressure and temperature, respiratory rate is about
All
25.
normal.
Respiratory rate about 25. Yeah.
Respiratory rate 25.
Yes.
Okay. الeye well
No,
jaundice.
no pallor, no jaundice.
الماوس any ulcer.
No.
I will hear the heart. Is there any pleural rub?
You can't, examination
Cardiac rub.
heart or chest? Hmm?
Chest
No.
heart.
Heart?
بسمع pleural
No.
rub.
No
Pleural
anything
rub.
in auscultation? No.
If there is any pleural rub or any
No.
nasal crepitation, anything in the
No.
chest.
Examination of chest really normal, but he decreased air entry because he can't take deep breath.
Okay. Abdomen. Is there any tenderness in the abdomen, any organomegaly?
Yes,
There is a
yes.
scar
You
on
will
the
excuse first to examine. He will say that he has tenderness in center of her abdomen, like
abdomen.
around umbilicus,
Hmm.
and you will examine just superficial palpation, and the examiner will tell you no need for deep palpation. It is
Okay.
lax, soft abdomen, no organomegaly you can feel by
Okay.
superficial palpation. Okay.
Is there any joint pain? Yeah.
No joint pain now, Dr. Lee.
Okay.
No.
Okay, I will examine the knee about the crepitus. If there is any crepitus, if there is any lower limb edema.
No.
Okay.
Normal.
Mr. Rajun, what's your concern, Mr. Ali?
Really, doctor, I start to thinking that I have a very serious problem because I think about my father. I fear about to be like him. I don't know really what happened to me, what I have.
2 minutes remaining.
I appreciate your concern, Mr. Ali, and from you said to me, and after I examined you, I am concerned about a condition called familial Mediterranean fever. Don't bother yourself by the name. It is a medical term for medical condition in which there is soreness in previous covering layers. There is covering layer of your lung, like I draw you now. This is your lung, and there is covering layer of your lung. There is covering layer of the gut, and there is covering layers also in lining layers in your joint. There is this in this disease. There is soreness in this covering layer, and it is. I'm sorry. It is a familial disease. Familial disease means run in family. Run in family. So that for that we need to do what we need to do now is to do some blood test and some imaging, and if the diagnosis is confirmed, will you give you some painkillers and some medicine to decrease the attacks, and I will fill you or give you also under close or follow up to to avoid to protect to know, and I will refer you also to okay, I will keep you under close observation and close follow up to give you good treatment and proper management plan.
Okay,
I think
doctor.
your
So
father
I'll become better, doctor, after treatment.
yes, it is controllable by treatment. It is controllable, and this inflammation and soreness, this soreness in the lining, it cured completely, and
So
the attacks may return again. So we'll follow up.
I can have kidney failure like my father.
I'm sorry to tell you that it is a possibility. It is a one of complication of this disease. It may lead to what we call in medicine amyloidosis, accumulation of some substances which may lead to the failure of the kidney.
Anything doctor can help me not to have this condition?
We will refer you to kidney doctor if there is any derangement, any decrease in the renal function, and we will discuss with him how we can improve your condition and decrease the possibility of
Okay.
having
Okay,
a kidney.
time is up.
Okay, thank you.
Yes.
Okay, what is your diagnosis, doctor?
This is Mr. Ali, 25 years old, coming with chest pain. He has history of recurrent abdominal pain and also joint pain. His father has the kidney problem and has skin problem during his young age. I think the first differential diagnosis is familial Mediterranean fever.
Anything in your mind for differential?
It may be angioedema, but there is no swelling. Also, it may be intermittent porphyria, acute intermittent porphyria, but there is no mental or mood disturbance. It
And
may
no
be
rush.
also. Huh?
No,
And no rush.
remember
Yeah.
the complaint is chest pain, not abdominal pain, Dr. Shaiba.
Yes, it's just pain.
Yeah,
Okay.
but you're mentioning abdominal pain.
Yes.
Okay,
He may be
symbolize the differential more, yes.
familial Mediterranean fever, maybe angioedema, maybe maybe chest pain due to pericarditis, maybe viral pericarditis.
Viral infection, yeah, viral infection, yeah.
maybe viral infection, maybe pylorysy نتيجة برضه viral infection.
It is
maybe
pylorysy. It is a case of pylorysy for differential, yeah.
yes, it is a case of pylorysy for differential. The main differential, first differential is familial Mediterranean fever. It may be due to viral pylorysy. It may be chest pain. It may be it may be GERD. It may be pericarditis. Maybe ischemic heart disease. Chest pain.
Yeah.
Pneumonia.
Yes.
Pneumonia.
Yes. Any other thing causing chest pain and fever?
Chest pain and fever.
In young, yes.
It may be pericarditis and pericarditis pneumonia.
Okay. What is the investigation you will do?
I will do a basic investigation. And I will do basic investigation, and I will do chest X-ray. I will do also ECG. Okay. And echo, ECG and echo.
Anything else? You will need an investigation. Basic. What is the basic? You said you have basic investigation.
CBC, complete blood count, renal function, liver function, and the electrolyte, erythrocyte sedimentation rate, and C-reactive protein.
Excellent. Okay, and the other thing is urine. You will do urine analysis.
I will do urine analysis and renal function test.
Okay. So, what is your management here? What you will do for this patient? What you will give?
I will give him non-steroidal anti-inflammatory drugs. If it is not related, I will give him colchicine.
And management for him. What is the for management? What is the management of the condition he has?
The main treatment in between attacks is colchicine.
Okay. Is the renal failure in this patient preventable?
Actually, it is not preventable because amyloidosis.
Amyloidosis because what?
Cannot be prevented. It is not preventable.
Do you know the cause of familial Mediterranean fever?
It is autosomal. Autosomal recessive.
Recessive, yeah.
Autosomal recessive disease.
Okay. So for the complication of this disease, do you know any complication for this disease?
It may lead to amyloidosis and renal failure. It may cause also carpal tunnel syndrome. due to amyloidosis also.
Okay. Okay, do you know any precipitating factor of his condition?
Precipitating factor, triggering factor for familial medical fever?
Mm.
I think it is precipitated by viral infection and stress.
Yes, excellent.
Stress and viral infection.
Okay. Okay. time كده خلاص.
Yes, time is up. So you can comment now, Dr.
Really, you was excellent, Dr. Shaima. Just you need to know more information about the familial Mediterranean fever. In the history, just you need to ask some questions to exclude dangerous causes of fever and chest pain. You really ask about chest symptoms, but it is complete. You should, after analysis the chest pain, ask about all chest symptoms. Also, if there is fever, you should ask also about any other problems with fever, like in the past. He can tell you that he has also fever. About and every month he has like bad fever that remaining days. And about the fever at this time, you also should exclude if he traveled recently, if he had any contact with sick people. So you will exclude the commonest presentation of this condition in clinic, like pneumonia. If he has recent travel, you will suspect and you will put early in differential. And if he has contact with sick people, you will put also in earlier in differential. For dangerous causes, you will exclude meningitis and rheumatic fever, very important, even if it's not common in UK. But if you have exam in other centers, the examiner will need you to exclude this rheumatic fever because it is like this presentation. Yes.
Rheumatic fever? How we can exclude it?
By question, just.
How we?
But and do you but also in differential? You said that you have recurrent throat pain, that you have difficulty in swallowing many times at young. Do you have problem at young? Any that you have fever for days and admitted to hospital like that? And if you will not ask, you just in differential you will put with the examiner. Okay. For examination. I think the neck stiffness will be also here. A murmur, you will you ask to auscultate the heart, but also not only the rub, you will auscultate murmur. For joints, you will see all joint, elbow and knee joint. For also if you will see neck lymph nodes to exclude also leukemia and lymphoma. About examiner questions, this condition, if you reduce the attack, you will prevent the amyloidosis, because the amyloidosis is the mechanism that is the recurrent inflammation. So yes, really you can prevent the kidney disease if we give colchicine for prevention. They found also if the patient not have very frequent episodes, he can take the colchicine only when he by the time the patient knows the episode when it started. He has like prodroma before it, so he will advise to start the colchicine with prodroma. And if he has like this patient have father with condition that is causing renal failure, you will advise to take colchicine as a prevention all the life. There is different.
يعني لو انا قللت النت يا عائشة يبقى قلل الاميلوز.
سوري again.
يعني لو انا قللت او بريفنتبل، يعني الاميلوز بريفنتبل.
Yes, preventable. Yes, it can be prevented if we take regular colchicine. And there is different genes found in this condition. If you will also mention in diagnosis, you may need to do the gene. Okay. It is not routine, but sometimes we do. In these cases, we do because he has renal failure history. So we'll do the gene because there is some genes the different gene mutation. Some gene mutation, good prognosis, and some gene mutation, bad prognosis. Okay, so with this bad prognosis, you will advise with colchicine more. And in the family, you will advise with colchicine more in prevention. Okay, for this patient, it is follow in rheumatology clinic. Okay, in inflammatory coordination with rheumatology. Also for this patient, you will advise to avoid stress, avoid alcohol, avoid what decrease sleep, avoid like all this will decrease sleep, like any stress in his life. This can precipitate. If it is female, you will and if also if he will do operation, if he will admit it for any problem, if he has any sickness, you will advise also to start colchicine if he will not take regular. Okay. For investigation, you missed only the genetic test. Okay. For management, you will set that this multidisciplinary team. You will he will under also psychiatric, and also maybe you will involve the kidney or the nephrologist for his condition to follow up regularly. You will tell him that he will under follow up regularly with rheumatology and nephrology, so he can avoid to be missed or to come late with amyloidosis, like renal failure amyloidosis. Okay.
يعني دلوقتي تعالى مع nephrology.
Regular follow-up, just regular follow-up, maybe every 2 weeks. The nephrologist will determine that. He will investigate and he will determine that. He can ask him to come every 2 or every attack, because he will pick up the amyloidosis early and he can manage accordingly. Okay.
Okay.
For complication of this condition, you should mention the problem with joint that is recurrent, because he will develop most of patients develop chronic arthritis, and it will be seronegative spondyloarthropathy also in the back. Also it is from recurrent inflammation. Complications like appendicitis, and he will already have appendectomy, and most of patients it is appendicitis, but it's like serositis, not really appendicitis, but it's if she didn't diagnose, they will mistaken it as true appendicitis. It is appendicitis, but it can treat medically, not surgically, but it is true appendicitis. It is serositis, so all over the gut, not only appendix inflamed, but appendix also inflamed. But if it is not diagnosed, and usually not diagnosed at this time, because it will be most of patients diagnosed under 20, so they misdiagnose that this is true inflammatory appendicitis and they remove it. Okay. Also, and you mentioned about the problem with kidney. This is the most dangerous complication. Also, he will have nephrotic, so we'll mention renal vein thrombosis, and it is one presentation of this case if not diagnosed by late, like after 30. If come in exam after 30, it come as nephrotic syndrome, nephrotic patient, and renal vein thrombosis. If the patient developed any, he asks you about management, and you will tell him acute, and he will require anticoagulation and for monitoring and like any management of nephrotic. You should mention in management, it's very, very important, patient education about the importance of strict compliance to daily colchicine. Okay, and the information about the family, you will offer brochures and offer the site of this, because it is rare condition, and maybe the patient will not understand in your meeting that's minute about his condition, so you will offer site, and you will offer like phones and any thing. You will not also when you really the patient ask one concern and you stayed explaining for about long time with this concern, just reply and wait. You will not mention all the management in the reply, just you'll say, tell that it's familial or it is hereditary condition and it is affect the cover layers as you said, and stop. If he asks another, you will reply another, but don't like mention a lot of things in one. This maybe the patient is confused and will not follow you. Okay, but generally you picked and you exclude a lot of differential, and you mentioned good differential, and a very nice case for you, Dr. Shema. I think you did it well.
Okay, thank you, Dr. Aisha and Dr. Shaima. I have a few comments. I will try to be short, but please, Dr. Shaima, write the scenario for Dr. Aisha. And my comment about the serious chest pain. As Dr. Aisha said, you have to rule out PE by asking about travel history. You miss the travel history totally, and still DVT and PE one of the possible. You can ask also the nature while or what increase the pain, like taking breath, or is it with the movement or with exercise? I think you miss also this point, but she mentioned to you with deep breath. So it's clear as pleurisy. The severity, the duration, also the ischemic heart disease, as the case Dr. mentioned yesterday, ischemic heart disease in a risky patient, but in this patient, he has or he hasn't any risk factor, but still you have to rule it out as ischemic heart disease. So for me, the differential, Dr. Aisha, chest pain, not abdominal pain. She mentioned all the abdominal pain differential. I mean angioedema and FMF, of course, one of chest and abdominal pain. But acute intermittent porphyria and angioedema, this is for abdominal pain. It will not cause chest pain. So what we can put here as differential for chest pain, pleurisy, musculoskeletal, or heart. This is what I will give. Chest pain in the chest. So the layers of the chest, either from outside the musculoskeletal or the lung itself, or pleurisy, or heart as a typical ones. Or you can put also PE in the vessels. So from outside to inside, I will give differential like this. But Dr. Shaima mentioned differential for abdominal pain. So please, I think we have to change the differential in this case. Apart from this, in the kidney failure in this patient, I should ask about medication. Is he taking over-counter medication? Because non-steroidal and over-counter medication may be the reason behind the renal failure, right, Dr. Raish?
Yes, yes, she missed both the medication and the travel, and this is very important here.
Yeah,
And if he take a lot of analgesic, you will also advise not to take it. Yeah,
exactly. He should be under nephrology or under GP observation, because one day he might have kidney failure, not because of the disease, but because of the medication itself. So she should ask, and she should give advice regarding taking over-counter medication. If she asks you in this way, you will give her a history of yes, I'm taking over-counter, and it might harm you. So the best advice is to take it after seeking medical advice. And it might be also the reason for kidney failure in the future if you didn't take it by prescription. Okay, let's go to the next scenario. Any question from others? I think the comments here also.
Infective endocarditis, not differential here in this case.
Infective endocarditis.
Differential. I think also differential,
liver, joint pain.
I think no, the risk factor also.
But no murmur, no injection.
And also, yes. And she should ask really for drug abuse, yes, here, and sexual history, yeah.
Okay. But infective endocarditis will cause chest pain. You mean as a complication of infective endocarditis? But infective endocarditis itself, patient will not present with chest pain. He might present with fatigue or difficult of breathing or fever, lymphadenopathy. But chest pain only if he has PE complicated to the infective endocarditis. But I don't think he will have pain.
When I asked her about chest pain, she told me it is increasing by breathing and it is mainly on the right side.
Yes.
فانت بتكسكلود مع يعني هي الحاجات دي موجوده مكتوبه
differential
you
في
put
الأول قبل ما تدخل لما
but you
بتيجي
put
لما
differential. Yes, you're right. But you put differential for
لا
abdominal
لا
pain. This is
لا
my
لا
point.
مش مطلوب abdominal pain. أنا انفضت يا دكتور لما قالت لي إيه تاني غير الفاميليا ميديتيريان فيفر، قمت قايلة اللي هم الأربعة اللي بيعملوا بريكرنت abdominal pain. دي كانت
أيوة this
لخبطة بس وأنا بتكلم،
okay.
لكن أنا كنت
Okay.
كاتبة سيست بين كان بيقول إيه.
Yes, take care. Give the differential for the complaint, not for the disease.
أيوه أيوه صح صح. بس هو
Okay,
أنا في دماغي إن الأربعة دول هم
no problem. It's okay.
الإديمة.
Yeah, okay.
أنا
We are
كتبت
training. Yeah, we are
أيوه.
training how to
فأنا بس
to
عايزة أعرف
give
لو واحد
information.
حابب يقرأ عن الفاميليا الميديتيريان فيفر يقراها منين كمعلومات؟ يقراها
Uh,
منين يعني؟
the best really and short is knowledge best medicine.
بس medicine.
طيب
Yes,
what is the relation between familial Mediterranean and nephrotic
nephrotic.
amyloidosis?
Yes, non-steroidal also.
هو ما يدوب بس كمان.
and
Amyloidosis.
ممكن
in
تعمل
management
vaginal necrosis، ممكن تعمل حاجات كتير، بس النفروتك من الأميلويدوز.
Yes, amyloidosis. And also
uh,
by in NSAIDs.
yes, and also you mentioned about NSAID as first line, Dr. Shaima. No, the colchicine always first line in this patient,
Yes,
not
colchicine
NSAID.
is the drug of choice.
Even in acute. Yes, even in acute and in prevention.
طب عايشة لو الواحد عايز يقرا عن الفاميليا الميديتيريان فيفر يقراها منين؟
والله أنا قريت عادي من أعتقد لأن أشوف كده الموقع اللي أنا جبته من عليه.
Okay,
وطبعا
doctor.
الحالة دي اتعملت معايا قبل كده، لكن أنا جبت
Yeah.
من الميدسكيب. هبعت لك الصفحة.
Okay, Dr. Aisha, prepare yourself. Mr. Ahmed,
طب هي
29
فين
years.
الكيس؟ 29.
Mr. Ahmed, 29, recurrent chest pain, blood pressure 142/90 for your kind care. Another chest pain.
اوكي.
Okay, 2 minutes, then we'll start. Dr.
هي فين
Muhammad.
طيب الحالة؟ هي مكتوبة؟
Okay,
تمام.
yes, you can see.
اوكي.
Okay, Dr. Muhammad asked question. She mentioned short of breath. Consider jargon? No, short of breath mean it's not jargon. It's a complaint. Any complaint by a patient, not jargon. So short of breath. Some patient coming to you, I am short of breath. Dyspnea is the jargon. This is the other medical or the jargon for short of breath is the dyspnea. Okay, so short of breath is not jargon.
Dr. Bassem,
Yes.
I think short of breath is jargon, and the non-jargon is breathing difficulty. That's what I noticed from the practice.
What you say again, please?
Just to be on the safe side. Yes, you are right. It's not jargon actually, but sometimes some examiners deal with it like as jargon. So
Some
just to be
examiners, Dr.
yeah.
You mean some examiner or some mentors?
Yes, I mean mentors.
Yeah, mentors. Okay, and how the mentor will judge short of breath as a jargon? Any examiner told the mentor this is jargon?
Actually,
I
I don't know.
Yeah, I don't know why is short of breath a jargon. I don't know why. Short of breath, short.
يا جماعة احنا اصلا لما بنيجي نسأل على اسئلة الكارديو كلها اني شورت زوبريس اني شورت زوبريس
Yes, any patient coming to Dr. Atif, any patient coming to the emergency, he say we are writing in the scenario or the document, patient came with short of breath as a complaint. So the most common complaint ever is short of breath. Who's the mentor is saying short of breath is jargon? والله sometimes this mentors.
I think dyspnea صح؟ dyspnea is jargon.
Dyspnea is jargon, yes.
Yes,
The
Dyspnea is
mentors
jargon.
always put us in troubles.
A lot of terms.
لا حول ولا
A lot
قوة
of
إلا
terms.
بالله.
A lot of terms. Actually, it seems just like it's not jargon, but sometimes they take it like
It's nonsense to be said by mentor. Short of breath is a jargon.
Okay.
Really,
خلاص
it's nonsense
maybe
at
you
all.
say difficult breathing to be
Short of
safe.
breathing, difficult to breathing, the same. But the main jargon here is dyspnea, not short of breath.
Yes. Yes.
Okay, we can start.
Yeah.
Okay, here we go.
Okay. Hello, I am Dr. Mitwali in the clinic. Today covering, may I speak to Mr. Ali, 29 years.
Yes.
Okay, hello, Mr. Ali. It came to my knowledge that you have chest pain. Can you tell me more about that?
Yes, doctor. Since 4 weeks now, I have the attacks of chest pain. I don't know why, doctor.
I am sorry for that, Mr. Ali. Do you need any help now or any painkiller?
Thank you. I just take.
Okay. Okay, I'll talk to you about this condition today, Mr. Ali, and I need to examine you. Is this okay with you?
Yes, doctor. Please.
Okay. So this chest pain is first time you have?
Since these 4 weeks only, doctor, I have recurrent attacks of chest pain.
I'm sorry for that. So, how many times you have this chest pain?
Many times.
And is this the same of this time also?
Yes, doctor, same.
And it is like remaining many days?
No, it comes and lasts for hours, 2 minutes to hour, then resolve, then come again. I don't know why it come and why it go.
I am sorry for that, Mr. Ali. And so it is on and off all these 2 weeks.
Yes, 4 weeks.
Anything help you to reduce it?
Nothing.
Do
Maybe
you,
painkiller, but for little.
you found that you with rest you are fine?
No problem. It can came in rest, it can came in exertion. It's not related to anything.
It is associated more with deep breathing.
No, doctor, no relation between it and between deep breathing.
Any cough with it?
No cough.
Any difficulty in breathing?
Sure, doctor, when this chest pain come, it came in a text. This text, I was very anxious and I feel heart racing and I feel headache.
I'm sorry for that. So you have heart awareness of your heartbeat when you have this pain in your chest.
Yes, doctor, yes.
Do you feel any dizzy with it?
I feel anxious, doctor. I feel anxious. And
Any
I feel
head and the headache.
Yeah.
Yeah. I found that your blood pressure is slightly high, Mr. Al. Are you know to have any medical problem or medical condition?
I have high blood pressure since 2 months now, and I am in running break, but it is not controlled also, despite this medication.
Yes, and this you just diagnosed with 2 months ago with this blood pressure high.
Yes, doctor.
Okay. Do you have any family condition I should be aware?
Yes, doctor. My father died because renal cell carcinoma. And my mother has
renal stones?
My father has the renal cell carcinoma, doctor.
Renal cell carcinoma. Okay, I'm sorry for
And he
your
died
loss.
at age of 50.
Your mother, who is?
My father died at age of 50. And my mother has removed his gland in front of her neck because cancer also.
I'm sorry for what happened, and I'm sorry for your loss, Mr. Ali. So you have any past medical history I should be aware of apart from this blood pressure?
No.
When this attack comes to you, you feel sweaty and you feel nervous, as you said, yes?
Yes, doctor, yes.
Do you have any swelling anywhere in your body, like lump or anything you notice?
No, I didn't notice.
Do you have any swelling in your limbs?
No.
Dr.
Okay.
Shemia, please, can you make your voice clear?
Do you feel that you have intolerate weather, like cold weather or hot weather?
No, doctor, no.
Do you find that you have some problem in your water work?
No,
Any fuzzy like water work, change in color?
no.
Okay. Do you feel any problem in your vision?
My vision?
Yeah. Your vision.
Yes, sometimes I feel some blurring of vision. But it is slightly, doctor.
So it is not permanent, like come and go?
Yeah, it
Or
is blurred. It is
Mm-mm.
not come and go. It is blurred. But I can overcome.
Do you find that we can't see side vision?
I think no problem. But I think there is blurring in vision.
Okay. Are you drive, Mr. Ali?
Yes, doctor.
I'm sorry to tell you that at this time, please, we need to stop driving, as this may be dangerous for your life and for others also. And you need also to inform the DPLA about your condition.
I am slightly blurred, doctor. It is not affect my driving. I can see. It is slightly
I
blurred.
know. Yeah. Yes, Mr. It's really also because this attack of high blood pressure and sweating and headache, it may be a problem in some time with to become a problem if you are with driving with this attack. Okay,
Okay.
Mr. Ali. Okay. So, Mr. Ali, do you have any difficulty in swallowing?
No, I don't
Okay.
have any difficulty.
Okay. Do you have any joint pain?
No,
Any
I
rash
didn't
anywhere
have
in your
anything.
body?
No,
Any tummy pain?
no,
Any abnormal movement in your body?
no,
Any weakness anywhere in your body?
no,
Any change in your bowel habit?
no.
Any weight changes last
Yes,
months?
doctor. Yes, I have weight loss recently.
How many kilo per this months? For this month, how
6
many months?
kilograms over 8 weeks.
And do you notice that it's intentional that you seek for that?
No, no, doctor. It is
And
not
your appetite
intentional.
affected?
Yes, doctor.
You have
think
less
that-
appetite?
Yes.
Any throwing up or being sick?
No,
Okay. Do you have any medication apart from Rabiprazole you are taking regularly?
medication?
Mm.
No, doctor. But I take recreational drugs.
For how many months or days do you take it?
Since 2 months now.
Do you know the name of this drug?
Yes, cocaine.
What is how you will use this drug? It is through what is the mode you can use? Through nasal or through mouth or through injection? Like needle يعني? Needle?
Injection. Yes.
Okay.
Sniffing. Doctor says sniffing.
Okay. I really advise you to stop this drug because it is really bad in your condition, especially you have high blood pressure and can lead to problem in your heart. And if you need help, I can refer you for
No, doctor, please don't say to anyone.
Okay, I reassure you that this remain confidential. Just I advise you. Okay, for you, are you smoke, Mr. Ali?
Yes.
How
I'm
many?
heavy
For how
smoker.
many?
10 cigarettes per day.
Okay, and really I advise also to try to stop smoking. This is very bad for your health and especially in your condition also. We can help by referring to smoking cessation clinic if you are willing that.
Who think about it?
Do you drink alcohol?
No,
Are you, sorry, I'll ask you some private question. Are you sexually active, Mr. Ali?
no. I am not married until now.
Yes, but you have any problem in your sexual activity?
No,
I'm sorry for asking this. Okay,
no.
okay. And with whom you live?
With my sister and mother.
Do you need any support? Do they support you?
Yes, they support.
What
They
do you
are
do for
support.
living, Mr. Ali?
I am a teacher.
Okay. Do you need any this problem affecting your job?
Yes, doctor, it is great. I am greatly affected, doctor. When these attacks come to me and I can't go to work.
I'll I'll try to help you by referring you to the occupational health services, and they can help you regarding that, Mr. Ali.
Okay,
Okay, may I examine you?
okay.
Okay, there is any high temperature now?
No,
No pressure standing, like sitting?
yes, it is 142/90.
Okay, I'll check any for pulse for both sides,
Equal.
equal and good, regular, and
Regular.
the rate is
95. 90.
okay. I'll check for pallor and jaundice.
No banner, no banners.
I'll check for any neck stiffness. You have any pain, Mr. Ali, in your neck? Can bend
No,
it as much as you can. Okay. I'll also check for the neck, any neck swelling in front.
no,
I'll
no, no.
okay. I'll ask him to just take sip of water if I notice the thyroid. I'll palpate the thyroid. Any tender or any problem? I can feel anything? No.
No,
Okay. I'll auscultate the heart. Any murmur?
no, maybe.
Okay. I'll after that I'll see the abdomen. It is anything, any scar, any problem,
No,
any observation. Okay, I'll palpate the abdomen in your organomegaly.
no, okay, okay.
Okay, after that I'll ask to auscultate the base of the lung um, from the back, and I'll see the back if there is any rashes or any pigmentation, anything.
No, nothing.
Okay, what is your concern, Mr. Ali?
I don't know why these attacks were just being doctor. Either I'm going to die as my father. Is it cancer, doctor? Is it cancer?
I appreciate your concern, Mr. Ali. From talking to you and after examining you, most probably have condition called pheochromocytoma. Don't bother you about the name. It is condition when you have swelling in the gland above your kidney, and it is secreted some protein in the blood, and it is causing to control blood pressure. In your condition, it is secreted in too much in your blood and causing very high or like episodes of very high blood pressure. This condition may be related to your family, but we need to test more about your condition to know if you have a familial condition that causing this problem, and we will monitor you so we can avoid to have problem like your father. Do you have any concern?
No,
Other
thank you.
concern?
You will
Only
Okay,
admit
so
me, doctor?
Hmm?
You will admit me?
Right now, yes, we need to admit you, Mr. Ali, so we can run some tests and we need to control your blood pressure, and we need to run image to your tummy so we can know the exactly cause of your condition and if we need urgent intervention or the procedure we can do. Also, we
What urgent procedure this you can do to me?
Again, the question.
What urgent procedure you will do to me?
we can need to take some sips or snips from your gland, so we know about its benign condition, and we can treat accordingly, Mr. Ali.
Okay. Thank you.
Okay, any other concern, Mr. Ali?
No, doctor.
Okay, time is up. Let's go to the examiner question. Dr. Shima.
Okay, what's your differential? What about your case about? What's your
Okay,
case about?
this is Mr. Ali, 29 years, come with attacks or episodes of sweating and chest pain and heart and palpitation. Also, it is come as on and off for the last months. He has history of hypertension also that is badly controlled, and he is on ramipril regularly. He has also he used cocaine, recreational drugs, and that is for the last 2 months. He also a heavy smoker. He lost about 6 kilograms for the last in the last 8 months, and
weeks.
it is not intention. 8 weeks,
8 weeks.
so 8 weeks, and it's not intentional. Okay, and he has positive family history of renal cell carcinoma and the neck cancer. I think it's thyroid cancer. In his okay, in this condition, I think about pheochromocytoma may be benign or malignant, and I also put in my mind also other like any adrenal, also any adrenal cancer
How
or
how this condition, which is called pheochromocytoma, related to his father or the mother condition?
pheochromocytoma may be part of like ليندو مش عارفة اسمها ايه هيبل فون هيبل
Yes.
syndrome,
Von
that is like carcinogenic genes in the families, run in the families, and so it can be a possible cause. Also,
Yes.
I'll put in my mind the cocaine that he used may be also the cause of his.
Still we are in pheochromocytoma. How it is related to her father and the mother condition?
It can also be part of men.
Yes.
Men too, A. It
Yes.
like medullary thyroid cancer and I think pancreatic. Maybe to the mother, يعني to the side of mother. Okay, and parathyroid.
What else? What other syndromes and what other disease can contain pheochromocytoma? We need to rule out.
I think it is men type 2A, and also 2A ولا 2B with mucosal neuroma. Okay, and
وهنا عندهم 2A و 2B عندهم pheochromocytoma وون هيبل لينكيو. في واحد تاني.
في واحد تاني.
في ديزيز كمان.
مين بقى؟ I think maybe the بس هو ما عندوش ريش. No rash. No virus.
انت شفتي بس
I ask. No, I ask about joint pain and rash. I'm sure. في rash في البيشن ده؟
لا.
Okay.
دي كانوا بقولك بس كده يعني. طيب. What other differential other than pheochromocytoma?
Okay, I'll put in my mind also renal artery stenosis and the drug induced.
Renal artery stenosis? العين جاي بشست pain.
Yes, it causes high blood pressure, and the high blood pressure will cause chest pain, angina. Like a high blood pressure will cause angina when it is like chronic hypertension. I think
yes,
yes.
It can also lead to flash pulmonary edema.
Why renal artery stenosis? ليه العيان عشان كان يعني؟
The age and the uncontrolled hypertension.
يا عائشة دلوقتي انت ليه بتقولي يا بينا الارتري ستينوزيس؟
عشان
ايه اللي يعمل
الايدج
كده؟
الايدج والهاي بلاد بريشر ذات نوت كنترول. الايدج يونج ايدج with high blood pressure.
ايوه،
My
ايه اللي
first
بيخليه يجيله؟
the first
ايه اللي
common the
بيخليه
commonest is scones. After that is renal artery stenosis, the second common cause for secondary hypertension.
طيب.
I think يعني maybe it is more
Yes,
far away
yes,
for
you're right.
chest pain.
You're right, Dr. Aisha, yes.
Mm.
As hypertension causes.
ايه تاني؟
Uh,
الكريم نفسه مش بيعمل شيست بين؟
for
الكريم
chest
بيعمل
pain
فيه شيست
with
بين.
high it's like episodic chest pain, so I think more about anginal chest pain and so in my differential يعني. But if it is wide chest pain أو it is regular يعني chest pain continuous chest pain maybe also pericarditis I think recurrent يعني pericarditis I think also about in his also in history of blood pressure high blood pressure we can think also I think I don't know but I think it is like
واحنا لو
episodic
حطينا ديفرنشال
يعني angina yeah.
طب بصي فهمتك، لو احنا حطينا ديفرنشال واسع اسمه شيست بين، سيبك من
yes
الهايبر مثلا وسيبك من ان هو ابيزودك، انت ما عرفتيش ان هو ابيزودك لما دخلتي.
بالظبط احنا قلنا هنقول
خلاص فاحنا
pericarditis
شيست بين، شيست
for
بين
this
عموما.
age yes angina first pericarditis second ممكن there is lung لو هنقول ممكن pulmonary embolism pleurisy pneumonia pneumothorax and also for anything else muscular pain maybe also.
جميل. طيب عندي كمان بيقول لك الاندوكراين، الهايبر ثايرويد والفيبروسايتوما يعملوا شيست بين، الاثنين يعملوا شيست بين وهاي بلاد بريشر.
Yes, yes, you're
يعني
right.
دي معلومة، يعني الهايبر
Because
ثايرويد
this
كمان
I
بتعمل شيست
examine the
بين.
thyroid
مم.
and ask about
مم.
thyroid symptoms. I miss the tremors. I miss the
طبعا.
tremors, yes.
بس انت ما شاء الله خلاص
But I
كده
think with
الوقت خلص.
hyperthyroidism,
اوكي.
خلص. With hyperthyroidism also would be diarrhea, would be hotness, and I ask about these symptoms she don't have. But
Okay,
it is
Dr.
very different, yes, high differential. Okay, comment.
Yes, done, Dr. Aisha.
لا.
Let's hear Dr. Shema comment. Yeah,
اوكي
you
ان
can
شاء الله
comment.
عملت كويس، ان شاء الله عملتها كويس جدا ان شاء الله. انا بس شايفه ان هي ايه والله انا شايفه ان هي عملت كويس ما شاء الله، وفاكر اللي بالله ربنا يكرمك يا عايشه وفاكر حتى. بس هو برضه نفس الكلام التراب يمكن احنا ما قلناهوش الدراجز، انا اللي قلت على لسه الدراجز انا اللي قلت
انت
عليه.
فتحتي لي الدنيا شوية.
انا كنت نسيها. بس ايه تاني، الهايبر كالسيميا المفروض كنا نبقى حاطين في دماغنا من، يبقى لازم نسأل على هايبر كالسيميا اللي هو هايبر باراثايرويدزم. انا عندي من تايب
انا
2
سألت
ايه
شوية حاجات
هايبر
يعني
باراثايرويد.
م.
ممكن نحطها في دماغنا. البوليوريا بعتقد انت بس سألتي عن البوليوريا.
سألت على البوليوريا وسألت على الطامي بين وسألت عن البول هابت.
لا بس محتاجين نحط في دماغنا ان احنا اول ما نلمح حاله فيكم سيتوما نحط في دماغك ثلاث حاجات، يعني ممكن تكون من،
المن
ممكن تكون
أيوة.
ايزوليتد، ممكن تكون ايزوليتد فيكم سيتوما، ممكن تكون من 2A و 2B. الفرق بينهم ايه؟ الفرق بينهم ان المارفينويد فيتشر واحده فيها مارفينويد فيتشر وواحده فيها كمان هايبر باراثايرويد
المرفانيت ده 2B صح؟
تقريبا. 2B
Yes.
هي اللي معاها مارفينويد و 2A هي اللي معاها هايبر باراثايرويد،
تمام
والاثنين
Yes.
معاهم ديمايسيستاسيون.
تمام.
تاني نقطة اللي المفروض نحط بيها في دماغنا اللي هو الون هيب لينج سندروم، اللي هو الفيجوال ديستربنس والابنورمال بيت. ماشي. ده الهيب لينج ده عبارة عن ايه؟ عبارة عن واحد عنده كل حتة انجيوما، هيمانجيوبلاستوما، ريتينال انجيوما، عنده عشان كده عنده فيجوال ديستربنس، بيكون عنده ابنورمال بيت، يجيله الترا سبيتش،
خلاص
الجيت
في كل حته.
كويس، يعني المفروض أسأل على الجيت هنا. تمام.
سيربيلر، يس، سيربيلر سيندروم، يس.
يبقى عنده
أنا بصراحة الكيس بتاعت فون هيبل دي بقالي كتير ما قريتش عنها. تمام فون هيبل، أنا حتى كنت ناسية الاسم.
هيمانجيوبلاستوما everywhere، ريتنا، سيربيلم،
في كل حته.
نيرفز،
وهي
يس.
مشهوره قوي بالرينال سيل كارسينوما، يعني اكتر عرض بيجي هو الرينال سيل كارسينوما. عشان كده لما اقول لك والده كان عنده رينال سيل كارسينوما يفكرك. خلاص.
تمام
طبعا
تمام.
اخر حاجه المفروض ان احنا نسالها اللي هي نيوروفايبروسيس السكين راش والايه والهيرنج ديفكت.
يس.
الهيرنج نسيت. الهيرنج برضو عشان برضو الهيمانجيوماس دي.
نو،
لا
فيستيبولار
النيوروفايبروسيس
الهيرنج
مش هو
والجيت
نوما. احنا عندنا تايب 1
والتريمور.
وتايب 2.
نسيتهم.
نيوروفايبروسيس تايب 1 وتايب 2. تايب 1 تايب 1 تايب
عشان
2 تايب منهم لازم يكون في عنده هيرنج لوس.
عشان كان في اكواستيك
سيربيلو
نيوروما دي في
بونتاين
انهي، لا
انجل،
دي في
سيربيلو
شوالوما
بونتاين انجل تيومر، شوالنوما، سيربيلو بونتاين انجل.
دي في الفون هيبل صح ولا فين؟
نو نو
لا
نو،
في
فور
انهي
بتكلم عن
حتة؟
تايب 2
نيوروفايبروسيس.
نيوروفايبروماتوز، تايب 2
تايب 2
نيوروفايبروماتوز.
في النيوروفايبروماتوزس. ايوه اصلا
تايب
النيوروفايبروماتوز
2
اول ما لقيتش راش خرجتها بره القصه خالص. تمام.
لا ستيل برين ستيم. تايب 2 كان هابن
نيوروفايبروماتوزس وتيوبرال سكليروز. ايوه.
yes. Tumor sclerosis known already by the finding. Skin rash subangular
خلاص
here.
طبيعي اصلا مش ما فيهاش فيه كروموسيتوما التيوبروسيس كلوروز. هنتكلم عن في كروموسيتوما موجوده فين؟ موجوده في مين؟
يبقى هما 3
وبي
حاجات: النيوروفايبروماتوزس والفون هيبل والمين 2 A و B.
ماشي. وممكن تكون ايزوليتد، يعني في الاخر ممكن تكون ايزوليتد. عشان كده احنا
اكيد.
محتاجين
ايوه.
نعمل جينيتك تيست. خلاص ماشي.
ايوه تمام.
الهايبرثيروديزم طبعا اللي من ضمن الحاجات الهايبرثيروديزم انت اوريدي حاجه مين عملتي الاكزامينشن بتاعتك. خلاص. طيب how you
حلوة.
will treat this patient? how you اولا اصلا ازاي تعملي investigation للبيشنت دي؟
طبعا الأول بيزك انفستيجيشن، السي بي سي بقى والانفلاماتوري ماركرز والليفر والكيدني فانكشن ويورين اكزامينيشن، وهنعمل الترا ساوند ابدومين او سي تي على طول. هنعمل انفستيجيشن، هنعمل كمان برين ايمج، هنعمل برضو ثايرويد فانكشن تيست، وهنعمل الكترولايتس.
specific investigation.
specific investigation
سبيسيفيك بقى جين بقى.
لا
الجين بتاع
لا ما في كروموسيتوما
في كروموسيتوما ليه الامفيتامين ده في اليورين باين ولا ايه؟
ميتانيفرينز.
ميتانيفرينز.
لا كاتيكولامين 24 اور يورينري كاتيكولامين وبلازما ميتانيفرين. وده مور اكيوريت. و24 اور
تاني معلش، تاني عشان انسيهم كده. اليورينري ايه بقى؟
24 اور يورينري كاتيكولامين.
ادرينالين.
خلاص.
تمام.
بلازما ميتانيفرين. وده البلازما ميتانيفرين هي مور اكيوريت.
ميتانيفرين. تمام.
خلاص.
تمام. ايوه. والايمج طبعا.
الايمج سي تي وام ار اي. لو ما ظهرتش عندك في الايمج وعندك بايوكيميكال انفورم يعني موجوده، انت شفتي الميتانيفرين يعني في البلازما عالي، الكاتيكولامين في اليورين عالي، هتعملي حاجه اسمها سنتيجرافي. يقول لك سنتيجرافي reserved for biochemically confirmed cases in which CT scanning or MRI doesn't show a tumor.
ده اللي هو بياخد حاجه مشعه يعني ويصور، مش كده؟
تقريبا كده يشوف بقى الحاجات الصغيره يعني.
تمام.
سنتيجرافي طبعا يعني حالة كانت تشيست بين أول حاجة تعملها لها بعد الروتين
ECG. صحيح. ECG. ضيعنا ECG. أي ECG أكيد.
بس يبقى
وكاردياك انزيمز، هنعمل كاردياك انزيمز.
يبقى احنا هنعمل بيزك انفستيجيشن، هنعمل ECG كاردياك انزيم وإيكو. بعدين سبيسيفيك انفستيجيشن فور كروموسيتوما اللي هي إيه؟ ال 24 اور يورينري كاتيكولامين.
واعتقد هنعمل بلاد كالتشر كمان عشان الراجل ده بياخد انجكشن، بياخد كوكين.
Exactly. You can send urinary also, urinary level, drug level.
لا مالناش دعوه بالدرجه ليفل بقى عشان الكونفيدنشاليتي، احنا بس هنشوف الكومبليكيشن.
توكسيكولوجي.
ما احنا كده عارفين انه خد كوكين، كان هنفتحه ليه بقى؟ هنعمل بس ان احنا نشوف الكومبليكيشن بتاعته.
طيب ازاي how you will treat this patient؟
التوكسيكولوجي ما بتتعملوش ابدا ولا تذكروا ابدا في الدايجنوزيس، لان الا لو المريض
Okay.
انت مش عارف هو خد ايه، لان
Yes,
ده
yes.
هتبريك الكونفidentiality. الا لو انت مش عارف
How
وعايز تعالجه، يعني عايز تديه انتي دوت.
how you
تمام.
will treat يا عائشة؟
طبعا هي المين definitive treatment هيبقى surgical, but we can control blood pressure till this management, and we can give something to protect the cardiac, and we can include بقى المالتي سكين روتين،
This time
النيورولوجي
how you will control how you control blood pressure؟ بتقولي control blood pressure.
بمالتيبل بقى ميديكيشن. الفا بلوكر المفروض اكتر حاجه، وبعدين ندي بيتا بلوكر.
Yes.
ما شاء
Yes.
الله، برافو عليك. انت عندك معلومات حلوة بس مفيش راسخة في
بس
نفسك.
ناسياها. بترجع
هي
يعني.
فعلا زي ما انت قلت كده السيرجيكال
البركه فيكم. بترجعوا.
هي السيرجيكال ريسكشن is a treatment of choice، بس لازم يبقى بريسيدد بألفا بلوكر 10 ل 14 يوم، وبتبدأي بألفا
أيوة.
بلوكر يومين، بعد كده تكملي معايا بعد كده بيتا بلوكر. يبقى
طيب
ألفا
لو
بلوكر
اديت
بعد كده بيتا بلوكر.
شنو؟
ايه؟
السؤال ليكم الاثنين، لو ادينا البيتا بلوكر قبل الألفا بيحصل شنو؟ ده
بيحصل
كلام
مشكله
حاجة
غلط.
كبيره.
بيحصل حاجة اسمها
كرايسيس.
هايبرتنسيف كرايسيس.
Sedation. Mm.
بيحصل
ايش؟
هايبرتنسيف كرايسيس.
Crisis.
بيحصل حاجة
Crisis.
اسمها هايبرتنسيف كرايسيس.
كرايسيس بيحصل برين هيموريدج in some cases.
Unopposed alpha action.
أيوه
Severe
أنا بوز ألفا.
vasoconstriction.
وبيحصل له
لازم
ام اي
نقفل
كمان.
الألفا الأول كويس، ونفضل يومين قافلينها وبعد كده ندي بيتا. الألفا قبل البيتا، يعني ألف قبل البيتا.
بس اسبوعين، بتقولي اسبوعين كاملين؟
لا، أسبوعين قبل العملية. البيتا الألفا قبل البيتا بيومين بس.
يومين. ايوه تمام. حلو
يومين.
تمام.
خلاص. طيب أنا بس هقرأ حتة صغنونة كده يقول لك إن في chromocytoma is a common case in the exam. In few chromocytoma you will find positive data in the form of loss of weight, racing of the heartbeat, recurrent headache, recurrent chest pain, recurrent sweating, shaking of the hand, high blood pressure. It may be isolated or involved within other syndromes like MIN2 or von Hippel-Lindau syndrome or neurofibromatosis that you have to ask about family history. Here is very important. Isolated phagocytoma may be familial in 10% of cases, autosomal dominant if involved with other syndromes. For example, you may find family history of father died because of cancer kidney. This will guide you to the possibility of inherited one Hebel Lindau. The exam case. كتبوا عليها exam case. The chromocytoma may come in different scenarios like recurrent chest pain, high blood pressure in young patient, palpitation, and like our cases. بس ممكن تيجي recurrent sweating.
حلو. شكرا دكتورة
Yes.
شيماء، حالة جميلة.
Yeah, by the way, the loss of weight here will be with the good appetite. يعني without loss of the appetite.
لا
هي
يا
قالت
دكتور، ليه
لص.
جود ابيتايت؟ ليه جود ابيتايت؟ هي العيان يعني هي بتبقى جايه على انها مالجنانسي يعني، مش
10% only malignant. 10% only malignant. Others are benign.
هي قصده ان هو فون هيبل، فعنده اصلا
The
مالجنسي في حتة تانية.
No. I mean in phagocytoma isolated you have you can find loss of
ماشي،
weight
بس هنا هي
with
مش
good appetite.
ايزوليتد، هو هنا قصدها بقى على الفون هيبل. هنا
لا
قصدها
مش
اصلا
كده،
هي
مش
الحالة
كده.
معاها
حتى
فون
لو
هيبل.
حتى لو ايزوليتد عايز تعملها زي
حتى لو
زي
no. It's
يعني
10% only to
thyroid.
be cancer. 10%.
لو
You
ايزوليتد
remember
هتبقى كده.
rule of 10? Yeah, you remember rule of 10?
Yes.
10 familial, 10 cancer, 10 unilateral, 10% bilateral. This is the rule of 10. So it's not a cancer in common in most of the
هو
patients.
بيسألك على
It's
فكرة، لما
benign.
بتيجي في الامتحان البيشنت بيسألك، فانت
لا
هقول له
Yeah,
there
you
is
can tell him,
possibility.
yeah, 10% to be cancerous.
بس مش هتديله برضو يعني هتديله bad news قوي، يعني هتقول له ان mostly it's benign but in some patient it can be
Yeah,
cancer.
some patients, yes. Okay, thank you, Dr. Shaima, for the case, Dr. Aisha. We are so late. I think all of others left or slept, but still we are awake.
We are sorry. Thank you.
No problem. Thank you. We'll try to make it shorter next time if you are interested to do after
خلاص يا عائشة، خلينا
the.
نعمل حالتين. لو هتدخلي معايا ندخل دكتور بس
It's okay. You can start
نقول
after.
عليهم.
ممكن
Uh,
احنا ممكن
I think in communication can be, but in long, I think it will be too long. In
okay, we
communication, we
can make it opposite. Communication followed
Yes,
by
it is
long,
better. Yes,
and the long followed by communication.
yes, it is better. It
Okay,
will save
and
time.
try to be together if you want. It's okay. For me and Dr. Sarah, for the exams, the sake of the exam will be started first. Okay. Then,
Okay,
if
no
you are
problem.
interested, you can send me. Okay.
Okay,
Thank you.
thank you. Thank you very much.
Thank you. See you tomorrow, inshallah. Good night. Thank you all. See you tomorrow. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Bye.